So a bit of overview about what we're going to talk about. I'll briefly talk about the long and short listing of it, the point system and whatnot. But predominantly this session is going to be focused on my experience with the AFP interviews, both in Birmingham and in London, where I ended up choosing. It's going to be heavily focused on the London station. We can have more open-ended questions for other sorts of interviews and applications later on. So that's what we talk about. So a bit about me. Before starting med school, I did a minor in arts, honors science degree, and then a master's in chemistry. And throughout med school, I was initially got into research through one of my friends who was a PhD research methodologist, who kind of got me into doing research in the medical field. Predominantly, I did mostly systematic reviews and meta-analyses. Haven't done any sort of primary study yet, and that's kind of how I got into it. In terms of choosing the AFP that I wanted to choose, there's a variety of different factors that you may have personally. So looking at all of the ones in London, for me, I think convenience and location was a big factor, because most of the AFPs, if you look at them, they're no different in terms of practicality to other foundation programs that you may have. You kind of have a year in central London and a year out somewhere else. So the only ones that I ended up ranking were the ones at St. George's and the ones at King's, because it's 2 years in the exact same location. So you kind of get to know the staff, you know the hospital a little bit better. And the reason why I chose the one I did was because it was the only one in London that offered a plastic surgery rotation, which is what I want to do in the future. And it's a bit of a misnomer, but it's titled under GP. There's no actual hard dedicated community placement for my program. My actual GP block is only about 2 days a week, and then the rest of it's dedicated to research. So don't only look at the names. A lot of the different ones, for example, vascular surgery at St. George's has no vascular surgery rotation. Just think about the rotations that might actually be of value to you in terms of what you want to do in the future. So the application itself is pretty standard. I think Oriel opened recently. When you apply, there's going to be a short and long listing. The long listing is primarily based on deciles and overall ranked academic and clinical performance. So in the year before that I applied, the year before I applied, I think the long listing cutoff was 6th decile and above. And in the year that I applied, it was 2nd decile and above. And it fluctuates and changes every year. So don't let your decile ranking that you've been given be too much of a deterrence for applying for AFPs. I think you should just apply. And that way, at least, you know, you have an option that you can take before the actual foundation program application rolls out. And if you're successful, you can decide to accept it, in which case you have a bit of a safety buffer, knowing that the SJT can't screw you over too much. Or if you don't like it, you can always turn it down and someone else will hungrily gobble it up. The short listing is mostly based on, of course, your academic performance, but also prizes, previous degrees, publications, and conferences. Previous degrees, you can't really change that much at this stage. You either have them or you don't, so don't worry too much about that. Prizes, try and keep it medicine orientated. But that being said, you can put previous scholarships and whatnot from university. Try and be a little bit sensible. As I was saying to Shahi, like, don't put, you know, your soccer participation medal from, you know, grade 6. Publications is a bit of a funny one. And I think much like degrees, they don't really care what it is, as long as it's PubMed indexed. So if there's a PubMed ID associated with your publication, that counts. Everything else does not. And previous degrees, so with a master's, I think based on their point system, it's equivalent to a first for an intercalated undergraduate degree, which is a total load of shit. But don't hate the player, hate the game. And if you have what you have, just use what you have. Also conferences, if you've attended them, if you presented at them, be it poster or oral, put it all on there. And if you're ever unsure, just put things on there, and it's up to them to decide whether or not it's actually worthwhile to allocate you points or not. Don't make a fuss too much unless you have a whole load of stuff that you could put on there. Try not to think too heavily about prioritizing what you want. So the London interview, before I get into this, it's going to be different depending on where you go. So for Birmingham, it was less formal and set like the London one. And it's a lot more open-ended questions about yourself. First in kind of, I guess, a clinical experience perspective, and another one more so research and academic orientated. And they can vary in time. So they can be anywhere between 10 minutes each, 5 minutes each, or a colleague of mine who previously interviewed at Oxford, hers were about 30 minutes each. So be prepared to talk about yourself a lot. But for the ones that are shorter allocation in times, like the London ones, you pretty much won't get much of an opportunity to actually talk about your own individual experience, and it's very heavily standardized. So for the London one, when I went, it was, you're all put in a room, you have 25 minutes, and you're given both the clinical station along with the abstract of a study. And you have those 25 minutes along with a blank sheet of paper to write down whatever you want, make of it what you will. And you can allocate however much time you have to either. So if you're very, very competent clinically, you can maybe say spend 10 minutes on that. So you can have a bit more time to actually read up on the academic station. The notes that you write down will be allowed to take into the stations with you. And there's always a copy of the scenario and abstract available at each station in case you want to review it. So don't think that you need to memorize everything. That's not really the whole point of this. There were 2 interviewers per station, and I don't think that's changed over however many iterations that they've done this for London. Just keep in mind that they will vary depending on how receptive they are to you, and it's not really a reflection of how well you do. So for some stations, you can go in and they'll be completely blank, other than like a polite greeting. They just won't say anything. And if you ask them questions, they'll kind of just shrug their shoulders and ask you to talk more. And other times they might just smile, nod the entire time, make you feel like you're doing really well, when in actuality you might be doing terribly. So make sure you have a system going into these things so that you don't miss anything. So generally speaking, for the clinical scenario, it's a ridiculous situation that basically almost never happens. But unlike real life, all your hypothetical kind of tools and colleagues along with you are incredibly competent at everything that you do, and nobody really gives you flack for actually ringing them up. The situations themselves, if you break them down into separate categories, they're very, very straightforward. But a difficulty with this part primarily is prioritization of who do you see first and what do you do in the meantime for patients who you're not able to see. We're not going to actually go through this scenario, but this is just something I'll give you 20, 30 seconds to read up and have a think about what you would do and what your thoughts are. Oh shit, what am I doing? Okay. Sorry, did everybody get a chance to finish reading that? Okay, I'll assume that everybody's read it. So in this one, you have a lot of different cases you need to prioritize. Keep in mind that you can use colleagues, you can bleep seniors, you can get things set up before you go see someone else. So for example, if you're not able to see one of the patients, you can ask the nurses for a full set of blood, some obs, and give them some oxygen and fluids while you go and treat someone else, okay? So I think it's important when you're dissecting and presenting the clinical scenario that you've been given, You provide an overview of what you're talking about, so the situation, and you should assume that the examiner has no idea what you've been asked to do, so that by the time you talk about the situation, they know exactly what's going on. You should always try and utilize the entire multidisciplinary team, because every single person in the team has a purpose that they can serve that can benefit you and the patient, more importantly. And you shouldn't be afraid to escalate and seek senior advice. A lot of things you may theoretically know how to manage, but in practicality, it's going to be quite difficult, especially with very little experience as an F1. So don't be afraid to ask for senior advice early on. And in terms of actually assessing and resuscitating a patient who's quite unwell, you should know your A to E like the back of your hand. You should know all of it, all the points, and the purpose and reasoning and rationale behind each one of those treatments and assessments that you do. And you should always be very confident. If you don't know it, you don't know it already, but not knowing it and getting flustered, it only makes people doubt the information that you present the rest of the time. So be confident in yourself. It'll make you feel better as well. And lastly, you should just do the reading and know the guidelines. An area I found helpful for most of the clinical scenarios that basically came up was just reading the emergency section in the back of the Oxford Handbook. Pretty much every common thing that you can encounter comes up there. So I think that's quite a good resource clinically to have and know well going into these interviews and life in general. For the critical appraisal, only the abstract is going to be available to you, so you can't see the full text. So whatever information is presented there is all the information that you have. There's no correct way of doing literature appraisal, but like all good methods, they should be systematic. And this is just to make sure that you don't miss anything and that you've considered the actual study from a variety of different perspectives rather than just simply reporting what the study and abstract have shown. So you will have to do this. You have to understand what they've actually said. You have to be able to describe it to someone else. And you have to critique or compliment the study, as a foundation of what is expected for you for this station. But you should always try and take it to the next step. And I think that's what gets you a bit more points on the interview system. So for example, I'll talk about this in the next slide. For example, you can talk about factors such as, the patient experience, the patient who's going to be experiencing the intervention that you're actually going to give them, the cost benefit analysis, which may impact on a public health level, and the ethics of the study itself. It might be unlikely if it's a short interview station, but you might be asked some open-ended questions about your own interests in research, how you got into it, what kind of things do you want to do in the future, and how might this position benefit you in getting to that place? So this is an example of an abstract that you might get. I'm not going to give you time to read it. It's quite long and whatnot, but sometimes they can be quite long like this. Other times they're a little bit shorter. Don't, get too flustered when you see something like this. Just slowly read it, dissect it down, write down what the key points are, what's the population in the study that they're looking for? What is the intervention, if there is one? Is there a comparator to a gold standard, or is it a comparator to a different study? Is it a superiority versus a non-inferiority trial? And what are the applications of this should the research hold up? So some questions that you could be asking, depending on what system you use, is what's the study actually looking at? What's the study design? Yada, yada, yada. But, are there any ethical issues with the study itself? Based on the study design, you should know what the different types of study designs are. Is it a case series? Is it a cohort study? Is it a prospective or a retrospective cohort study? Is it a randomized trial? What exactly is the design of the study? And what are the differences between them? So you should know the difference between a case series versus a cohort study. And what patients did they select? How were they chosen? Could this create a source of bias? What interventions? Why these interventions versus something else? And what are the pros and cons of each? And how are they being compared? Is one superior? And what are the cost-benefit analysis? So you might find that this new trial of this drug that's absolutely incredible, but it's going to cost $1 million a pop. So is it feasible? Is it realistic? Is it going to change anything? And what are the end findings? And how would it impact you? So a question that I got both in London and Birmingham, was if this study was true, and a patient was sitting in front of you, what would you do? What would you give them? Would you give them this or would you give them that? So practice lots, practice both of them. And I think one thing that I found particularly helpful is practice with people you don't know well, because you're not going to know the interviewers. And no matter how well prepared you are, sitting in front of two people who are strangers to you, who are above your station from a medical perspective, it's going to be intimidating. And they may not always react to you and give you hints and clues like your friends might even subconsciously do. So practice with people you don't know that well. Even if they're not going for an AFP interview, just say, would you mind interviewing me and critiquing me for this kind of practice? And try different styles. So if you're rehearsing with your friends, you can say, for this time, I want you to absolutely grill me. You can interrupt me at any single point, ask me tons of questions about this. And that's quite a tough thing, because you might get into the habit of practicing and you know your system really, really well, and you have a nice ebb and flow. But whenever someone interrupts you and asks you something, you might get flustered and you lose track of what you were talking about. So try different styles. Try styles where you say absolutely nothing. Hearing yourself talk for 10 minutes straight with no feedback whatsoever is total shit, because you begin to hear your own voice and you realize you've made mistakes here, you've said something wrong there. So get into the habit of trying different things so that you're familiar on the actual day of the interview. That's pretty much it. So we'll open it up to just general questions now. Should I stop sharing screen, or what do you think?
Just keep it on that, and I'll read you out the questions. So we've got one that's just came in a bit ago, but I'll read it out to you. So it says, do you feel AFP students are treated differently or get a different experience compared to standard foundation students in clinical practice?
No. No, you're not. I think the only times that you're treated slightly differently would be more so by your peers than anybody else. And it's more so of a, ooh, AFP, fancy, cool. And then it's quickly forgotten. So you're not kind of put on a pedestal. There's nothing special about it, other than the fact that you have it.
Cool. That's the only question we've had so far. So anyone else, if you've got some questions, feel free to send them in. Oh, new one. Okay, from anonymous attendee 2. Do you feel that you get sufficient surgical experience in the AFP program?
It depends on the it depends on the surgical job that you have. So being quite frank, the foundation program is largely in place as a service provision. And it falls upon the individual to kind of better themselves, both clinically, surgically, academically, and whatnot. So knowing that some fields are more busy than others, I kind of scouted out my plastics jobs ahead of time, and it would have been fantastic if it had not been for COVID and I couldn't rotate onto it. It was basically just all theater. And other foundation jobs, you might find that, especially if you're doing general surgery or orthopedics in a major trauma center, there's tons of patients. So at any given time, you have at least 40, 50 patients that you need to do, albeit very minor jobs. They still take a lot of time. So you might find that you don't actually have a lot of theater time. One nice thing that I think, and this isn't particularly AFP specific, is that once you actually qualify and you become a junior doctor, if you ever are inclined to and you take free time out and you liaise with people and say, I really want to do XYZ, I have today off, would it be okay if I join your theater list? People are a lot more accommodating, they're a lot more friendly, and they generally allow you to do a lot more, and they teach a lot more than when you were a student, I found. So there are tons of things you can do, if, especially if you're interested in surgery, which requires a good amount of surgical experience before you apply to higher training programs, to take these opportunities and just use a bit of your own free time to get more experience.
Awesome. Thanks very much. There's loads of questions that have come through now. So the next one is, do you feel that you get sufficient surgical experience in the AF? Oh, that's the one we just did.
That was the one, yeah.
What resources, apart from Oxford Handbook, did you use to prepare for London interviews?
Honestly, not much. Some people bought books, kind of telling you what research is, how it's conducted, how to apply for grants, how to critically appraise papers and whatnot. It's not necessary. And if I can go back to one of the slides, boom. This is something I slightly forgot to mention. So your interviews for the London one, it's 2 stations. Each one of those are 70 points. You get graded out of 10. So whatever you get is multiplied by 7. I smell smoke. And you have your actual decile ranking out of 43. If you get top decile, you have 43. Bottom decile, you have 34. And then you have your actual application and portfolio, which is worth 100 points in total. So those total up to about 283. For the clinical one, I got 10. And then for the academic one, I got 9. I didn't use any sort of formal resources that told me to, do things a certain way. You can literally Google how to critically appraise a paper, and it'll give you 5 or 6 different methods that you can use as a structure. So in short, no, it's not going to be necessarily the crux of what makes you interview well in that station. But if you're interested in research in the long run, I don't think there's anything wrong with getting a book like that and preparing in a bit more of a structured and formal way. And a resource, I suppose another resource that you've kind of been using the entirety throughout med school is actually being on placement and being in hospital and understanding what roles each specialty fills, when to refer to other specialties, when things should escalate. For example, if I ask you right now, a patient needs to be taken emergently into theater, but your reg is on the way to assess them. Is there anything that you would do? And, without really having too much clinical experience, you might say, I don't know, maybe consent the patient, but you can't really consent the patient. Things that you could do to help get the ball rolling is contact the emergency theater staff and the on-call anesthetist. So knowing what kind of personnel are available is going to be a good way to distinguish someone who has actually been in placement or not.
Thank you. That was very, very helpful. We've got a couple more. So would doing an AFP over a normal FP help or give extra points when applying for a core surgical program or any other specialty?
For core surgical, if you look at the actual core surgical applications, and they release them every year and they update them every year, there's no points that you get there's no factual hard points that you get for core surgical. I don't know about others. I think Hamid Khan has consistently mentioned that he has gotten extra points, but I think he went into GP. And you might get it for medicine, but you don't get hard factual points for core surgical training. What you get, I guess, is an opportunity at the interviews to talk about yourself in a way that, I guess just purely based on numbers and statistics that a lot of the other applicants actually can't talk about.
The next question is, number 1, how long did it take to get longlisted, then shortlisted for interviews at London?
Don't remember.
Okay. Number 2, did you apply elsewhere? And number 3, would you still put down conference presentations even if the conference ended up being cancelled/postponed to after the application deadline? So I guess that's because of COVID or whatever reasons. If it's been moved on to the next year, should you still mention it?
Okay. So the long and short listing, I don't remember the exact dates and whatnot. I just remember I remember my interview was before the SJT, and I wrote my SJT in January. So it would have been, I guess, in a couple of months from now, 2-3 months from now, and you'll find out. I think the long listing is relatively quick, but you don't really get notified that you've been accepted to the long list. So, yeah, I think it happens relatively quickly. I don't Anyways, did I apply elsewhere? I applied to Birmingham and London. You're only allowed to apply to 2 places for the AFP. It's not like the foundation where you can kind of rank all the different deaneries within the entirety of the UK. You only apply to 2. And would I still put down conferences present? Yeah, I absolutely would. So I think due to COVID, people from first year medical students all the way up to consultants have been, to a large degree, butt fucked. And it's just, everybody understands that it's an unfair situation to be in and that there's only certain things that you can do. If you're accepted to it, I would 100% put it down and just, if you're asked to, I guess, provide evidence, be it an email or something like that, saying you have been accepted, but it's been canceled or postponed to a different time, that's 100% still something that you have achieved because you would have done it had it not been for this. So yeah, 100% put it down.
Thanks very much. Yeah, I think that was a question that a lot of people I've spoken to have had in terms of the COVID stuff. So that's really, really useful to know. The last question that we have is, how does allocation of projects work? Do you have to do a project in the area your AFP is for? And how much scope is there for change?
It varies depending, okay, how to allocate a project. So it can be quite variable. Some places you go and there's a list of projects and you just tag one on. A lot of people who do this typically have a project in mind, so they may already liaise with people to get the project rolling, and so you do that in advance before you even secure a post. And honestly, even if you don't secure an AFP, it's not like you can't do research. So you should just aim to do whatever you want to do anyways. How do you have an area project? You do not, no. Generally, the AFPs are themed. So, for example, one might be GP, one might be microbiology. Just because you're allocated to, I don't know, say Brighton, doesn't mean that you can't do a virology or a microbiology project based in London, because it's going to have wide applications regardless of where you are, right? That's the whole point of research. And how much scope is there for change? Can you specify that a little bit more? I don't know what that means.
I guess maybe, I mean, I didn't ask the question, but I'm going to assume maybe they mean like how, like, can you go from, I don't know, general surgery to something completely different, like dermatology or something, or does it, does it have to be within the general kind of area? I'm not sure. So maybe if the person comments again, we'll know.
Okay. Well, to that end, it depends on the field that you're tagging it on. So medicine is quite interrelated as a general topic. I mean, all the different specialties can in some way kind of relate to each other. I chose the GP one because everything can kind of relate to primary practice. So I was kind of lucky in that regard. You can basically choose whatever project you want and have some tenuous attachment to GP. So you're not completely limited. Others might be a bit more strict, but that it's going to be quite variable, and I can't really answer for every single one. So that's all I have to say about that for now.
One more question, which is, would you recommend George's as an AFP choice based on your experience to date?
I would, for a couple reasons. One, it's actually really, really nice to be at the same hospital and to know its workings and to know various people in different departments. It actually has a great impact on the way that you can practice in terms of efficiency when you know everybody by first name. And I think the AFPs offered at George's, a large number of them they're GP-based, vascular, or renal. Those are the 3 different categories that you can have. The GP and vascular ones have the exact same supervisor who is quite lax about what you want to do. So that's a positive. And the renal one, who a friend of mine's doing, who's also a St. George's grad, the guy organizing it or is leading it, it's Dr. Banerjee, who basically kind of tells you exactly what to do And it's a very kind of efficient system and has already a project for you in mind if you have trouble getting one on your own. So all in all, I think I've had a really good experience. It would have been nice to, see a different part of the country or a different part of London. But if I remove the fact that I've been here for the past 4 years as a student, for 4 years as a student before the start of foundation, I'd be very, very happy about my choice.
Thanks very much. And new question that's just hot off the press. Were you ever asked what type of project you wanted to pursue for your AFP, or with who you wanted to work with at any point during application?
During the application, you have opportunities. So, for example, on the Oriel system, depending on where you apply, there's white box answers as well. Not just London's very cold and everybody's just kind of a number. Whereas other places, I think because of the white box answers, you have an opportunity to distinguish yourself and separate yourself from everybody else. If you have an interest, you can talk about it and your previous experiences and why you wanted to choose that project. So it's something that you can slide in, and it's something that you can slide in at interviews, but hopefully not too much to the point where you don't actually answer their questions and you just end up talking about yourself. I would say that certainly for places that have longer scheduled interviews, like Oxford, they will 100% ask that. Places like London, where I finished the critical appraisal station with like maybe 3 minutes to go, and they asked a bunch of open-ended questions, and I was able to talk about what I wanted to do kind of at that point. But just because you say something in terms of your interest in a project doesn't mean that you're glued to it for the rest of your life. Everything's quite fluid. So if you have an interest and you have a project in mind, that's great. But if you don't, you should think about and maybe perhaps talk about what you'd like to do in the future and how this program might help you kind of achieve that.
Thank you very much. I'm just gonna also say I'm posting in the comment section the feedback form for Ming for this session. It's really, really useful because people can use it, as I'm sure you know, as part of their portfolios and part of kind of their training in the future. So it's really, really helpful for Ming, but also just it would be helpful for us to know how we can improve the sessions as well. So it'll be on the chat box now. So please, please, please fill it out. And also, if you do fill it out and you put your email address in, there are a couple of prizes that you can win. I think they do it every month from the feedback forms. There's a raffle, and there's a year subscription to Amboss. There's the venipuncture arm you can win, so you can practice on that if you want. And there's loads of stuff. So I highly recommend it. I'm just posting it now. In the meantime, we've also got 2 more questions, one of which is Longlisting national or region-based?
National. So you have your performance throughout med school. Up until final year, you basically get a score of your composite kind of academic and clinical achievement. And that'll be the score that you have. Of course, it's graded against your own colleagues at your own medical school, but that is your final score nationally.
Thank you. That's very, very helpful. I wondered that as well, actually. And then is there a website with a list of all the AFP programs with the rotations, or did you look at the deaneries individually?
So when you apply to the 2 deaneries that you want to potentially go to for the upcoming 2 years, if you're successful, you'll have to excuse me. I don't remember exactly how Oriel worked and how this process worked. I'd remember, what I do remember is having the 2 deaneries that I applied to being, I guess accepted for the long list and shortlisting. And before the interviews, you'll have an ample amount of time whereby the 2 deaneries that you apply to, it lists every single job in that deanery. And you should have a good amount of time to actually sift through and figure out what you want. You can rank as many or as little as you want. So for example, I only ranked about 14 of the 125 jobs in London. And For Birmingham, I literally only ranked one.
Thanks very much. So I think that's all the questions that people had. One question that I wanted to ask, but I think you've kind of answered it, was about the deaneries. So it seems like there's 2 deaneries you apply for, and then within that, those 2 deaneries you rank. Is it just the AFP posts that you have to rank?
You only rank the AFP posts.
Got it.
So this will be a ranking system that comes far before the normal foundation posts, which have like hundreds and hundreds of jobs. Depending on the deanery you apply to, you may have anywhere between, I think London's going to still be the biggest. You may have anywhere between, I think, 20 to 30 or 125, like it was in London.